So there is a momentum in healthcare. And where is your momentum taking your organization? So I'd like to first thank Margaret for inviting me here today to specifically share the physician perspective on the momentum in healthcare today, and also specifically through the lens of an integrated healthcare system. So what are our challenges, our issues, our concerns? What are our successes and failures? What trends are we seeing? So I hope that after this presentation, each and every one of you gain new insight that we can use collectively and collaboratively so that we can all continue delivering that high quality and affordable patient care that our patients expect, and that we also expect for ourselves as well as for our own families. So I'm going to start with a story, and it starts in Hawaii on the big island of Oahu. And it's a story of a patient of mine, a 31-year-old healthy, happy young man who enjoyed the island life, worked as a bartender and a server, and who met the love of his life at the restaurant he worked at. Now, at the age of 31, he was diagnosed with cancer, with leukemia. And so he and his wife decided to move to the mainland, and about a year later received a bone marrow transplant from the City of Hope. Now, to be closer to support a family, they moved between LA and San Diego County, and he essentially received care from 5 different hospitals, from one in Hawaii, 2 in LA, 1 in San Diego, and at the City of Hope. So already, this story demonstrates the benefits of integrated care to the patient. Imagine yourself in a similar situation, but not in an integrated system, or without an interoperable electronic medical record system, and the coordination that would have to happen for something as simple as obtaining your medical records, all the labs and the reports from all the different departments and physicians at 5 different hospitals. So because of integration, there is better care coordination and communication between providers. There is the infrastructure for a team-based approach to healthcare, and care is more efficient and cost-effective. You don't need to reorder the labs and the MRIs and CAT scans because they're available for all to see at all the different locations. So it reduces waste and redundancy while increasing efficiency. So since I was asked to specifically give the physician perspective within an integrated healthcare system, how do we define integrated care? What is integration? Now, the World Health Organization defines it as a concept bringing together inputs, delivery, management, and organization of services related to diagnosis, treatment, care, rehabilitation, and health promotion. Integration is the means to improve services in relation to access, quality, user satisfaction, and efficiency. So there are a multitude of ways to look at integration, and I would share 2 key points that aren't really emphasized here, and the first is agreement. Agreement between the different stakeholders, between the doctors, the pharmacies, the hospitals, the health plan. And second, a shared culture. A shared expectation of how care delivery will be given and better outcomes achieved. And I'll be coming back to this throughout my presentation. So integrated care is more convenient for our members, it facilitates communication between different providers, but how does integration improve quality? The quality of care for the individual patient, but also for our population. How does this agreement and culture of care between the different providers enable us to find efficiencies that reduce costs, improve or maintain quality, and allow for innovation? So, first, integration drives successful team-based care and better care for the patient. So this is a screenshot of a care gap list that I can see in my own clinic as an eye surgeon for one particular patient. And it's the opportunity for me to counsel that patient at that visit about and help them get the preventative care that they need. So it's not today just the family physician and the internist who's monitoring the diabetes or looking out for the next vaccine that's due. It can be the brain surgeon, the dermatologist, and the eye surgeon that can help with all of these primary care needs. And another example of a patient I had, this patient entered our system poorly controlled, had a vitreous hemorrhage, which is internal eye bleeding. You can see the yellow flag on the right there, and got well controlled very quickly, still controlled. Seeing me now in follow-up, no longer has eye bleeding, but he was due for his hemoglobin A1C lab test. So I saw that, I referred him to the lab, he got the lab. The primary care physician saw the good result and emailed the patient, offered him diabetic health education around healthy diabetic eating, and he accepted the course. Now, diabetes is the #1 cause of vision loss in the United States under the age of 65. And if you have the infrastructure and a robust electronic medical record system and an innovative telehealth program, you have the ability to impact the care of a population. And we're able to monitor our diabetic patients remotely across the United States via our telehealth monitoring program. Last year, we screened over 174,000 patients in Southern California alone via a central reading center, and now we're reading photos from patients in both Colorado and in Georgia. This is one particularly striking example of why integration and coordination matters. Opioids. Our data systems and our clinical integration detected this issue 7 years ago, and we took immediate action. Because of the agreement between the medical group, the pharmacies, and the hospital, we were able to develop a comprehensive and strategic approach to an issue as complex as opioid use, and the ability then to reduce the destructive potential of the opioid epidemic in the communities that we work in. So from 2014 to 2017, we decreased high-dose opioid prescriptions by 39%. We decreased brand name OxyContin prescriptions by 75%. And what's the importance of that? Well, OxyContin has higher resale value out in the community and a higher risk of diversion into our schools and community. And you might ask, how did we do this? Well, this was via a multidisciplinary approach. We developed an opioid-sparing pain management program that had 4 critical elements. First, patient education. Second, physician education, patient safety, and community safety. And this work was actually recently presented in Washington, D.C. to the President's Commission on Opioid Use. Now, because of integration, you can also set very high goals, including cutting colon cancer mortality in half within a decade. And it's a goal that we're on track to meet. Our screening rate is 82%, which is nation leading. Our 5-year survival rate is 80%, which is 13% higher than the national average. This is kind of like our cancer moonshot. But what we're doing with data just like this is we're now extracting that data and extrapolating it to different areas like health disparities. So in our African American population and with hypertension or high blood pressure control, we now have been able to take our controlled patient percentage to 75% to almost 90%. And for this work, we recently were recognized with the inaugural award from CMS, the Health Equity Award, for the work that we're doing in reducing disparities in our Medicare population. Now, I include this because only in an integrated system would you have a hospital agree to installing this little drive-through drop-off box for your colorectal cancer screening kit. And I find this amusing. I just hope we don't get any mail in that box. So there are challenges to physicians in an integrated system, and it's not unlike the challenges for physicians outside of an integrated system or in a partially integrated system. So first, escalating drug cost, and especially direct marketing to patients. You know, it's not just about the Claritin ad that you see on TV in the fields, it's now the cardiology drugs, the expensive chemotherapy drugs, the arthritis drug that you see here in the upper left, marketing to our seniors who are at home watching TV. It's the regulatory environment, keeping pace with innovative delivery systems in areas like telehealth. As we heard yesterday, state and federal health policy, and as we just heard earlier, data. How do we harness the collective power of all that data. And then physician workforce and physician wellness. This is a significant issue inside and outside of integrated systems. There are less and less physicians entering the primary care workforce, and the reason for this is likely multifactorial. But one reason is likely because of entering a specialty that historically has a higher income. And why? Well, in 2014, the median medical school debt was nearly $200,000. And do I have colleagues and a friend who owes $360,000 in medical student debt? Yes. Now, on physician wellness, burnout, work-life balance, these are all important issues for many of us in this room, and for that reason, our medical group has a robust physician wellness program. So what are some of the outlooks and trends from a physician's perspective from within an integrated healthcare system? So I thought it would be helpful. I do wear a couple of hats, as Rick had mentioned, and I thought it would be helpful to share some of the thoughts and discussions I had from some of the leaders of the two organizations, both the California Medical Association as well as America's Physician Groups, or APG. And I will make a comment. APG right now is truly the nation's largest voice for physician groups that practice within an integrated model. So from the physician perspective, in this kind of global shift from volume to value, you're going to see more and more physicians moving away from the solo private practice kind of model and more into group practice. And it's one reason is to access that infrastructure and that electronic medical record system that's going to make it easier to report on all these quality and performance measures. You're going to see less fee-for-service and more risk-based contracting like capitation. From a systems perspective, more integration and coordination. More physicians and medical groups partnering with hospitals for the infrastructure and potentially because it's likely a more viable model in today's healthcare milieu. Technology, more innovative, more cost-effective health strategies like telehealth, more on data, predictive analytics, and AI. And then from the patient perspective, more of a shift onto population and community health, and specifically on obesity and prediabetes, and all the social determinants that come with those chronic diseases. And the corollary of that is more of an emphasis on prevention and less utilization at the hospital and inpatient level. And lastly, team-based care, an emphasis on team-based care, and not just because of the physician workforce issues I mentioned earlier, but because it gives better and more complete care of a patient. And this brings me back to my patient. So in 2012, he received his bone marrow transplant. Fast forward about 5 years, and he unfortunately developed graft versus host disease. And this is when your immune system aggressively rejects a transplant. And you can see that his appearance has changed here, and this is a photo with his wife on his birthday, about a month prior to me meeting him. And I was consulted because he had really increasing left eye pain and pressure. And so throughout the hospitalization, we really got to know each other well, and I really started looking forward to my visits with him. We talked about, him as a bartender, how I did a little serving at Georgetown. We talked about Hawaii. We talked about his 5-year-old son, Charlie, who was named after him and was named Charles Beck IV. And I got to meet his brothers, just an incredibly nice family. So I know there's some physicians in the room, and for the rest of you, you're going to get a little bit 3-minute tutorial on how to read an MRI. So this is actually an MRI, and you can see right here, this dark area here, this is a really bad sinus infection that had started to spread to the left eye socket. And what was especially concerning is that here, you can actually see, this is the base of the brain on the right, and here, see this enhancement here? Concern for spread to the brain. And here's another view here. This is his right orbit or eye socket. Here's the sinuses all enhanced, and you can see the spread here, this enhancement, and again, enhancement of the brain. So spread of the infection into the eye, which was causing all this pain and pressure. So this MRI, this particular MRI, was done at around 2 a.m., late at night. And I was calling physicians and surgeons at 2 a.m. And I truly believe it's not just because I work in an integrated system, that I had access to an infectious disease specialist, an oculoplastic surgeon, and a head and neck surgeon all around 3 a.m. And of course, they all have access to the scan remotely. But it's because we share a culture of care. And this patient was actually scheduled for surgery just a few hours later that same morning. Now, I did go and see him post-operatively in his room, and he was, already had less eye pain impression, was very grateful to have had the surgery. But the concern is that the surgeon shared with me that he thought this was a serious fungal infection. And it's a simple fungus that you and I breathe in every day. But with someone who has an incredibly weakened immune system, it can be deadly. And so as I was in his room and I was sharing, we were discussing this, I looked on his bedside table to the left, and what I saw was this little small stuffed sea turtle. And that's when he shared with me, oh, that's from my 5-year-old son who picked that out for his sick daddy. So you ask, why integrated care? It's not just cost. It's not just about efficiency. It's because as a physician, I truly believe that I can give the best possible care to my patient in this type of system and no other. And it's not just because I can freely practice the art of medicine or the good that I can do as an individual, but what I can offer in the complete care of a patient and their family. So when it was noticed that the infection had spread to the brain and later to a carotid artery, it was deemed inoperable and non-surgical. And that's when Mr. Beck shared with me that he was tired. And he very willingly accepted the services of our hospice or end-of-life care service. And he was so ready and happy to go home. Now, this is a photo of a hospital hall I cross through frequently at work. And I'll share that Hippocrates said, the father of medicine, cure sometimes, treat often, comfort always. And it was when I could look both his wife and his parents in the eyes and say that I truly believe that we did everything that we could for him, they knew I spoke the truth. And it was then in my heart and in their hearts that we could let him go home. And he passed away a week later in this past October. This patient's life left a beautiful mark on my own life, on both a professional and a personal level. And when I reached out to his wife to ask for her permission to share my experience with him today, she thanked me for my kindness and gentleness, and then shared photos of the life that he had already shared with me. And she then shared that his ashes would be returning to Oahu in about a month. So I'd actually like to dedicate this talk in the bright memory of my patient, Mr. Charles Beck, and also to his son, Charlie Beck. Thank you.